Welcome to the deep dive. Today we're taking, well, a really focused look at one of the most clinically critical areas in medical imaging.
Gynecologic oncology.
Exactly, gynecologic oncology. We're going to be extracting all the essential knowledge, the must-know facts, the strategies, the nuances directly from the Atlas Gynecologic Oncology Imaging.
That's right. So if you're a learner, maybe you're a resident prepping for rotations, or you just need a really comprehensive, accelerated review, this deep dive is for you.
What's the mission here?
The mission is to build a clear diagnostic roadmap. We're going to distill the core principles for evaluating ovarian, endometrial, cervical, vaginal, and vulvar cancers.
And we'll be looking at all the tools.
All of them, emphasizing the practical utility and sometimes the critical limitations of ultrasound, CT, MRI, and of course, PECT.
Okay, let's unpack this. I think we have to start with the most formidable challenge in the field, the one that, well, it so often presents too late.
Ovarian cancer.
Ovarian cancer. It is tragically the most lethal gynecologic malignancy. When you look at the data, the 5-year survival for advanced disease is still just stuck at a devastating 30%.
It's a terrible statistic.
And that alone really underscores why accurate early imaging is so vital.
Right, and its lethality is, it's intrinsically linked to how it presents. It shows up at an advanced stage, it spreads rapidly through the peritoneal cavity.
So just for a foundation, where are we looking anatomically?
We're looking at the ovaries, which are usually situated laterally to the uterus and just inferior to where the common iliac vessels split.
And the origin point.
Crucially, the surface epithelium. That's where the majority of these really aggressive tumors originate.
So given that challenge, how do we even begin to approach the diagnosis? There's a sort of hierarchy of imaging, isn't there?
There is. And I always think of ultrasound as the indispensable starting point.
The first-line evaluation?
Absolutely. US is the undisputed first-line tool for any suspected ovarian pathology. Why? It's accessible, it's cost-effective, and it gives us real-time visualization. It's our triage tool.
And then, if something looks suspicious, we move on.
Then we bring in CT, but primarily for staging. It's fast, it's reproducible, but we have to recognize its weakness.
Which is?
The soft tissue resolution is just inferior to MRI. It doesn't give you that same level of detail.
So that brings us to MRI. When do we commit to the higher cost and, the complexity of an MRI scan?
MRI is really reserved for when we need superb tissue characterization. So when a lesion is indeterminate on US or CT, or if we need to confirm the local extent before a surgeon goes in.
Okay. For the learners out there, what does a normal ovary even look like on MRI?
That's key. A normal ovary will show a low to intermediate signal on your T1 weighted images, but then on T2, you'll see those normal fluid-filled follicles stand out. They'll be really bright or hyper-intense.
The ultimate goal here in the imaging suite is really to predict malignancy, right? To give the surgical team that critical heads up they need.
Exactly. And we have specific US features that act almost like a binary decision tree. Are we looking at something benign, or is this a huge red flag?
So what are some of the good signs? The reassuring features?
Well, the positive predictive value, the likelihood that it is what you think it is incredibly high for benignity in some cases. For example, a simple unilocular tumor, just one single cyst, has a 99% PPV of being benign.
Wow, that's almost certain.
It is.
Yeah.
Or a smooth multilocular tumor, as long as it's under 100 millimeters, that also hits that 99% mark. These are excellent reassurance signs.
But then you have the red flags, and the whole strategy changes instantly. What sends up the highest suspicion for malignancy?
You're looking for irregularity. An irregular solid mass, for instance, has a 96% PPV for being malignant.
And other signs, like fluid.
The presence of free fluid in the abdomen, ascites, that's another high-level indicator. That's a 97% PPV.
Well, what about blood flow?
Right. Using Doppler, if you see strong blood flow within the mass itself, which indicates high metabolic activity, that pushes the probability to 88%.
And these findings, they aren't just academic.
Not at all. These findings dictate whether a surgeon plans for a standard removal or a radical debulking procedure right from the get-go.
So once we have that suspicion, the imaging report shifts. It's all about staging.
Staging becomes the most critical role imaging plays.
What does the radiologist absolutely have to include in that report to help the surgical team?
For the T stage, you need precise measurements, all 3 dimensions. You have to state if it's unilateral or bilateral. But the crucial detail is the characteristics.
What kind of characteristics?
Are there enhancing solid nodules? Are the septations thick and irregular? And because we know intraperitoneal dissemination is the main route of spread,
You have to look for that.
you have to specifically call out metastatic deposits in sites that would make cytoreduction impossible or extremely difficult. Mentioning those non-resectable locations is paramount for the initial treatment strategy.
So imaging is the initial roadmap, and then it becomes the surveillance tool post-treatment. We know CA-125 is used, but it has its limits.
It's helpful, but it's imperfect. Normal CA-125 values absolutely do not exclude recurrent disease, and elevated values don't tell us where the disease is.
Which is where imaging comes back in.
This is where high-resolution CT and MRI come back into play. They can be comparable to exploratory surgery for detecting small residual peritoneal implants. And this imaging is essential to determine if a patient is a candidate for a secondary cytoreduction.
Okay, fascinating. So if ovarian cancer is the lethal ghost, let's pivot to endometrial cancer. This is the most common uterine cancer.
And it's often linked to established risk factors like the rising rates of obesity.
The clinical presentation here is a bit clearer, though.
Much clearer. It typically presents as postmenopausal bleeding, which drives that initial U.S. evaluation, and the hallmark imaging finding is a thickening of the endometrial cavity.
That endometrial stripe.
Exactly. It's a critical metric. In a postmenopausal woman, if the endometrial thickness is less than 5 millimeters, the prevalence of cancer is very low, about 0.6%.
But if it crosses that threshold?
Cross that 5 millimeter threshold, and the prevalence just jumps sharply to 19%.
So that threshold on the initial US is incredibly powerful for deciding who needs a further workup.
It is.
And once that threshold is breached and we suspect cancer, MRI takes center stage for the local staging. Why is MRI so superior here, specifically?
MRI is just the most accurate modality for assessing the depth of myometrial invasion.
And that's clinically vital.
It is, because the depth of invasion dictates whether a patient might be eligible for a fertility-sparing approach or just how extensive the surgical resection needs to be.
Let's get a little technical for a moment, because the timing of the contrast administration seems to be a key diagnostic trick here.
It is the absolute key to local staging.
Why is that?
We are looking for the maximum contrast between the normal, healthy myometrium, which enhances rapidly and looks bright or hyperintense, and the tumor, which enhances poorly and looks dark or hypointense.
So there's a specific window you have to hit.
A very specific window. It occurs optimally between 50 and 120 seconds after the contrast injection. If you miss that window, assessing the depth of invasion becomes much, much more challenging.
And you mentioned cervical stromal invasion. How do those delayed images play into that?
That's a separate but vital check. We take delayed images maybe 3 to 4 minutes later, and those are essential for ruling out FIGO stage 2 disease.
So involvement of the cervix.
Right. We look specifically for the intact enhancing cervical mucosa. If that mucosal enhancement is broken or invaded by the dark tumor, that's stage 2, and that's a major shift in prognosis in the treatment plan.
Of course, we also have to contend with benign findings that can look concerning, which can easily confuse a new learner.
Right.
What are the common mimics in the uterus?
Oh, we constantly battle 2 main culprits. First, adenomyosis.
What's that look like?
It's characterized by a thickening of the myometrial junctional zone, that inner layer of the uterus, with multiple tiny punctate cystic spaces you can see on T2. It can make the uterus look abnormal, but it's not cancer.
And the second one?
Leiomyomata, or fibroids. Benign, extremely common masses from the myometrium. They often show up as these heterogeneously enhancing masses after contrast. They can really distort the cavity and mimic tumor extension.
And just a quick note on distinguishing different types of uterine cancer. We have the epithelial type, which relies on depth of invasion. But what about the less common, more aggressive sarcomas?
That's a crucial staging nuance. Leiomyosarcomas and endometrial stromal sarcomas, the non-epithelial types, are staged differently.
How so?
They use tumor size to define stage eye disease, not the depth of myometrial invasion. It's an easy point to overlook, but it's vital for proper staging.
Okay, let's transition now to cervical cancer. This is a real success story in public health, isn't it? Mortality has declined dramatically.
Largely due to pap smear screening, yes. HPV types 16 and 18 cause about 2/3 of cases, and the most common histology is still squamous cell carcinoma.
But there's a modern challenge here.
There is. We are seeing a rising incidence of adenocarcinoma, which is unfortunately less efficiently detected by standard screening methods.
And for learners, there's a really important concept here, the FIGO staging paradox.
Oh yes, the rule that often trips people up.
Tell us what that FIGO rule dictates.
So, FIGO staging for cervical cancer is based on clinical findings alone. Physical exam, biopsy results, basic x-rays, maybe an IVP.
And critically,
The assignment of the clinical stage does not permit the use of high-tech modalities like CT, MRI, or PE.
that seems counterintuitive. Why is that?
It's an intentional historical rule, really, to ensure all patients globally can be accurately staged, regardless of their access to advanced imaging.
So even though these are basically mandatory for planning modern therapy, they don't count for the official FIGO clinical stage.
Precisely. They are invaluable for evaluating the true extent of disease, for surgical planning, monitoring response, but they don't set that initial clinical stage. And when we are evaluating the local extent, MRI is far superior to CT.
What's the specific technical trick that's essential for an MRI of the cervix?
It's all about the plane. You need oblique T2-weighted images taken both perpendicular and parallel to the cervical canal.
And why are those specific planes so important?
They are essential for the accurate evaluation of perimetrial invasion. If the tumor breaks through the normal low signal of the inner cervical stroma and involves the tissue lateral to the cervix, that's perimetrial invasion, a hugely significant local staging finding.
Let's talk about post-treatment imaging. This can be a real diagnostic minefield. After radiation, how do we distinguish between scar tissue and inflammation versus actual persistent tumor?
That is the ultimate challenge. Radiation causes inflammation, necrosis. It can all mimic a residual mass.
But what's the telltale sign?
The single most reliable indicator that the cervix is successfully tumor-free post-radiation is the reconstitution of the normal low-signal intensity cervical stroma on imaging. If that stroma is nice and dark, we are reassured.
And if there is a recurrence?
If recurrence occurs, it typically presents as a soft tissue mass that shows a higher T2 signal than the surrounding muscle, often indicating active, viable tumor.
Okay, let's quickly wrap up the lower genital tract, starting with the vagina.
Remember this critical statistic for vaginal malignancy? Less than 5% of these are primary tumors.
So most of what we see is metastatic.
Most of what we see is metastatic disease coming from the cervix, vulva, endometrium, or even non-gynecologic sources like the rectum or breast.
So the key takeaway here isn't just identifying the primary tumor, but understanding where it drains.
Exactly. The lymphatic drainage pathways are a practical imperative for surgical planning. The upper vagina drains into the pelvic nodes obturator external internal iliacs.
And the lower vagina.
The lower vagina drains to the superficial inguinal nodes. Staging, which is T1 to T4, relies on MRI, and we often use lubricating gel to distend the vagina slightly.
And that helps with?
It helps us measure wall thickness and invasion into the paravaginal tissues or adjacent organs like the bladder or rectum.
Moving to vulvar cancer, predominantly squamous cell carcinoma, staging is largely surgical, but imaging guides those plans. What's the single most important prognostic factor here?
Lymph node status, that is the factor that dictates survival.
And how has the approach to that changed?
Historically, a radical inguinal lymphadenectomy was performed, but it carries significant long-term morbidity. So modern practice now favors sentinel node mapping for early-stage SCC.
For smaller lesions.
Right, for lesions under 4 centimeters with non-palpable nodes. It's a strategy to minimize that morbidity while still getting crucial staging info. PTCT is often used here due to its high specificity for extranodal disease.
That sets us up perfectly for our final tool, FDG, PETCT, the metabolic powerhouse. What is its main advantage in gynecologic oncology?
FDG, PTCT, assesses metabolic activity through glucose uptake, and that lets us accurately detect distant metastases, the M stage, and critically non-enlarged lymph node metastases, the N stage, that look structurally benign on CT size criteria alone.
It finds the cancer that's hiding.
Exactly. It's the ultimate tool for systemic staging.
Where does PTCT truly change the management game?
In cervical cancer, its primary benefit is twofold: detecting unknown distant metastases before definitive treatment starts, and identifying those smaller, metabolically active lymph nodes that you mentioned.
And for endometrial cancer.
It's highly useful for surveillance and restaging recurrent disease, especially since high uptake has been strongly linked to a poorer prognosis overall.
This functional imaging, though, powerful as it is, comes with physiological pitfalls. Radiologists need to be wary of those.
They do. We have to account for normal physiological uptake that can mimic malignancy.
Like what?
Endometrial and ovarian uptake varies wildly depending on the menstrual cycle. For example, during menstruation, you can see high central uptake in the uterus. A normal maturing follicle can also show intense uptake. We have to correlate the scan date with the patient's cycle.
And the preparation sounds rigid but essential.
It's non-negotiable. Patients have to fast for 4 to 6 hours, and the most critical prep is ensuring the blood glucose is under 200 mg/dL.
Why is that so important?
If the glucose is too high, the body's own glucose competes with the tracer, the FDG, for cellular uptake. That drastically reduces the sensitivity and increases the risk of a false negative result. You could miss a metastasis.
This has been an incredibly detailed diagnostic roadmap through the major sites of gynecologic oncology, really emphasizing the strengths and limitations of each modality.
To crystallize that roadmap, then, we rely on US for initial screening and triage. MRI provides the precision for local staging, especially for myometrial and parametrial invasion.
Yeah.
And PTCT handles the systemic staging and recurrence surveillance by mapping that metabolic activity.
A truly integrated approach.
Modern oncology absolutely demands this integrated, multi-modality approach.
Before we close, here's a final thought for you, the learner, to integrate these concepts. Think about this. We discussed the precise need for delayed imaging in endometrial cancer MRI to evaluate cervical stromal invasion. But for ovarian cancer MRI, we look for enhancing solid components immediately after contrast.
That's a good one.
Considering the anatomy and the different routes of spread, why is the timing of that contrast evaluation utilized so differently to answer those two very distinct staging questions?
A great point to reflect on.
Thanks for tuning into this deep dive. We hope this accelerated roadmap helps accelerate your mastery of key gynecologic oncology imaging principles. We'll catch you next time.